some topics of pediatrics from Toronto Notes. It's 2025 PDF. And the topics I'm going to cover today is failure to thrive, rash, child abuse or neglect, and some developmental disorders like global developmental delay, ADHD, and autism. So I'm going to read them at a pace that you'll be easy to understand. It will be easy for you, and so be with me and watch till the end. So you will get some important points to remember among these topics. All right. So let's start with our first topic, that means failure to thrive. Okay, so failure to thrive basically means when a child is not gaining enough weight or a weight is less than the third percentile and falls across two major percentile curves on the growth chart. So on the growth chart, as you have seen sometimes when we go in pediatric clinics, they have a growth chart and they basically check child height and weight according to this growth chart and tell us whether this child is growing normally or not, who is gaining weight normally or not. So if it falls across two major percentile curves, two major, so basically if its percentile is getting two major decrease on the growth chart or less than 80% of expected weight for height and age. So if the child is not growing well, falls less than third percentile or two major percentiles across the growth chart or less than 80% of expected weight for height and age, then is called failure to thrive. All right. So, inadequate caloric intake, most common factor in poor weight gain, may have other nutritional deficiencies, for example, protein deficiency, iron, and vitamin D. That we need to keep in mind that failure to thrive children, they are deficient in protein, iron, vitamin D, and the factors affecting the physical growth include basically some factors we need to remember like genetics can play a role, intrauterine factors means pregnancy. During pregnancy mom was having malnutrition, that can be a factor. Nutrition deficiency for the children, some endocrine disorders, chronic infections, and some psychosocial factors, all these can lead to failure to thrive. So here is written just the mid parental height. We need to know main thing that we need to know here is clinical signs of failure to thrive. The clinical features, as already mentioned here as well, small kid as a good mnemonic, they have a loss of subcutaneous fat loss, right? Then the muscles become atrophic, and then can be loss of hair in the children. Children can show lethargy, they are lagging behind normal. They can show severe malnutrition in the form of kwashiorkor. That means that the child can be having edema and abdominal distension and some infections and some skin rash in the form of dermatitis. So all these things are basically clinical signs of failure to thrive. We need to have a rough idea. If a child presents to you with the very atrophic muscles, loss of subcutaneous fat, extreme lethargy, and recurrent infections history and rash history, so we need to think that maybe the child is having failure to thrive. So other that in history is also important to know that if a child comes to you, what we need to ask? We need to ask about the nutritional intake, very important, then the feeding behavior of the child, then current symptoms, past history, family history also very important, and the psychosocial history is also important. Then physical examination include basically the growth parameters. We have to check the weight and height of the child and plot it on the growth chart. And less than 2 year we check three things: height, weight, and head circumference. And if it's more than or equal to 2 year, we check height, weight, and BMI. Then vital signs, complete head to toe examination, evidence of chronic diseases, chronic infections, chronic illnesses, upper to lower segment ratio, sexual maturity staging, signs of maltreatment or neglect. Neglect can also be the cause of child malnutrition, or maltreatment is also can be the sign of uh, failure to thrive. Investigations are important, that if a child comes to you, what we need to do? We need to do CBC, the blood smear, all the routine investigation, electrolytes, thyroid, then urea creatinine, then ferritin, serum iron, because as we already read that iron, they may be deficient in iron, calcium, and vitamin D mainly. So we need to check ferritin, calcium, vitamin D, celiac screen, because celiac screen children, they also have a low weight gain, and there can be show symptoms of malnutrition. And then bone age x-ray, then the chromosomal karyotyping, and chronic illnesses if a child is suffering from, then do chest x-ray. And cardiac, we need to check the condition of heart. We need to do x-ray, ECG, echo, GI, celiac screen, inflammatory markers, malabsorption, renal, and liver. So basically, if a child comes to you with failure to thrive, we will have a broad array of investigations that we need to keep in mind. We will look on every aspect. Either the child is suffering from any chronic conditions, from any genetic conditions, from any heart conditions, any GI conditions like celiac disease, any vitamin or mineral deficiencies like iron, calcium, and vitamin D deficiency, any thyroid hormonal disorders like thyroid hormones. And along with this, we need to check the kidneys and liver of the child, and along with the routine tests like CBC. And so all these things are very important. Then okay, now we need to see in this table what they want to tell us: the failure to thrive patterns. Okay, this is something we need to remember. My target is to make Toronto notes palatable and easy to digest, so I will make try to simplify them as much as I can. So period to thrive patterns, one pattern is if there's a decreased weight. Okay, only the weight is decreased. The first pattern, as you can see here, decreased weight, normal height, and normal head circumference. The cause may be caloric insufficiency or decreased intake. Simple. Because of child is not gaining weight, but height is normal, head circumference is normal. So either there is a dietary deficiency that we need to remember. Then, if the child is having decreased weight, decreased height, but normal head circumference. So height is decreased too, along with wear. So maybe some structural disorders, some endocrine disorders can be there. Again, if the child is having decreased weight, decreased height, and decreased head circumference, all things are decreased, then we have to see whether we have to ask history of pregnancy and delivery of the child, or maybe some changes that happen during the delivery, and as well as the pregnancy intrauterine, something happened to the child during the pregnancy period. All right. Etiology. There are lots of factors that play an important role. There are complex factors include basically the dietary intake, the feeding environment, the parent-child interactions, the child behaviors, the some social factors like stress can be very important, poverty, neglect, child domestic abuse, parental substance misuse. All these things are very important. Okay, inadequate caloric intake, if the milk supply is not good, mechanical feeding difficulty, or a motor dysfunction like cleft palate and cleft lip, child they are not able to take their feed properly. And then inadequate malabsorption like conditions like celiac disease, inflammatory bowel disease, cystic fibrosis, milk protein allergy, increased metabolism in infections, cystic fibrosis, lung diseases, thyroid disorders, increased losses from the body, increased utilization in chromosomal disorders, and certain prenatal factors. For example, during the delivery of the child and pregnancy, if there was any infections, any genetic conditions, maternal conditions like diabetes or renal disease of the mom, and the mom was using certain medications during pregnancy which may be teratogenic, they're not good for the children. Then drugs and mother tobacco or alcohol use, and that's called fetal alcohol syndrome. That also shows that when mom is taking alcohol during pregnancy. Okay, then management, mostly as outpatient using multidisciplinary approach. We need to remember one word: there will be a multidisciplinary approach, okay, and the primary care physician will be involved, occupational therapist, dietitian, psychologist, social worker. Then the medical management include basically some treatment of the iron deficiency anemias, the reflux problems maybe, and then the cleft palate, those things that need to be treated. Nutritional management include basically education about age appropriate foods, calorie boosting, mealtime schedules, okay, current nutritional deficiencies, and promote catch up growth or development. Behavioral positive reinforcement means mealtime environment, no distractions during mealtime. Okay, the next topic I'm going to cover here is pediatric rash. So we can see it's a table that shows various pediatric rashes. Although the rashes will be more discussed in the dermatology chapter, but here we need to know some pediatric rashes. One rash is diaper dermatitis, a very common condition that occur in children who wear diapers. So basically, differentiation can be irritant contact dermatitis, seborrheic dermatitis, candidal dermatitis. Appearance will be important to remember that shiny red macules or patches, no skin fold involvement. Okay, if the child comes to you with a shiny red patch in the diaper area, but the skin folds are not involved, and management will be eliminate direct skin contact with urine and feces, allow periods of rest without a diaper, frequent diaper changes, some general measures, topical barriers like petroleum jelly, zinc oxide paste, short term low potency topical steroids. If this case is very severe, then we can use short term low potency topical steroid is a very good table. So the different thing here I need to remember is in diaper dermatitis, the appearance will be shiny red patch, and the skin folds will be spared, no involvement of the skin fold. And the management will be general management first, that we have to clean the area, we have to eliminate direct contact with the feces and urine, and frequent change of diapers. And then we can use certain ointments like petroleum jelly, zinc oxide, and short term steroids can be given as well in cases which are very severe. All right, next thing is seborrheic dermatitis, that is yellow greasy pellax on erythema a scale. Seborrheic dermatitis are always remember the thing will say yellow greasy. When it says yellow and greasy, we say the term seborrheic. Okay. Then short term moisturizers can be used, topical antifungals, because this is a kind of antifungal treatment is needed for that. So we can use some topical antifungals for this purpose. All right, so topical antifungals can be given, and then low potency topical steroids. So remember that for irritant contact dermatitis we just give barrier ointment like zinc oxide, petroleum jelly, and some low potency topical steroids. For seborrheic dermatitis we give topical antifungals and then low potency topical steroids. And then for candidal dermatitis, then the rash will be erythematous, macerated papules or plaques, satellite lesions, and there will be involvement of skin folds. Okay, so irritant dermatitis, irritant contact one, no skin fold involvement. But if it will be candidal, then it will be involvement of skin folds will be there. And again, the treatment will be giving antifungal agents, clotrimazole and nystatin. Alright, so diaper dermatitis can be three types that we have read here. Irritant contact, no involvement of skin folds, seborrheic dermatitis, yellow greasy rash, and candidal dermatitis, that is papules or plaques and involvement of skin folds. Irritant contact, general measures, and then barrier ointment, seborrheic and candidal. We give antifungals, we need to remember. Alright, now some other rashes. One is the atopic dermatitis. Dermatitis is simply eczema and atopic allergic. So reddish papules, plaques, there will be lichenification. Eliminate the exacerbating factors, maintain skin hydration. We have to use daily moisturizers, corticosteroids, topical calcineurin inhibitor, but this is second line. So main thing we need to remember is topical steroids as well as the moisturizers. Then nummular dermatitis, that is in the form of annular erythematous plaques, annular or round erythematous, like it goes, just remember the circle, it goes like this maybe, and plaques oozing and crusting. Avoid irritant if identified. Potent topical steroid in emollient based short term steroid therapy and antibiotics can be given. So I zoom it a bit more so it's easy for you to see this table. Right. Now next thing I can see here is allergic contact dermatitis. First we read in diaper it was irritant contact, now allergic contact dermatitis. There will be red papules or plaques, vesicles or bully, and the mild we give the soothing lotion, the calamine lotion, and for moderate we use the low potency intermediate potency topical steroids. Then irritant contact dermatitis, here we see avoid skin contact. Dyshydrotic dermatitis, that is in the form of cracking or fissuring, especially cracking or fissuring in the especially on hands and feet. So for mild and moderate cases what we need to do, medium or potent topical steroids. For severe cases, steroids again. Then infections, we need to know some infections like scabies. Scabies is a very important infection that can happen in children. And then polymorphic rash that occurs in the form of red excoriated papules and nodules and burrows. Okay, the word burrows, if you see in a stem, definitely scabies. In the web spaces or web folds, very important, web spaces, web fold and burrows, very pruritic, often affects multiple family members. So scabies is present in the form of burrows, linear burrows. Just remember by this linear line, linear burrows in the basically web spaces or web folds, very itchy and often affects multiple family members. Okay, the treatment will be permethrin cream 5% for patient and family as well. And we give in the form of two applications 1 week apart. Impetigo. Impetigo is honey colored crust or specified bully. So honey colored lesion, that is known as impetigo or superficial bully are there. Mild topical antibiotic causes a bacterial infection, so we give topical antibiotics. Fusidic acid cream or pupirocin cream. And for severe, we give oral antibiotics like cephalexin, erythromycin. Then the next rash here is tinea corporis. Tinea corporis, round erythematous plaques, central clearing and scaly border. So tinea corporis again it will be round reddish plaque, central clearing and scaly border. We give topical antifungals for the skin, systemic antifungals for nails or head. Next topic I'm going to cover today is child abuse and child neglect. Okay, child abuse and child neglect is quite much information is given here, but it's easy, and we'll just read and try to understand what's exactly they want us to know. What is child abuse? An act of commission. Commission means physical, sexual, or psychological abuse. So, an act of commission or omission. Omission means neglect by a caregiver, guardian, sibling, relative, other individuals, stranger, teacher, support worker results in harm or potential harm to the child. That's a very nice definition that you can see here. All right. So an act of commission. Commission means child abuse, a very good topic for MCC QE1, and we need to know what does it exactly means. An act of commission, that is a physical assault, a sexual assault, or psychological abuse, or omission. Omission means neglect, and it can be done by a caregiver, a guardian, a sibling, a relative, any individual like stranger, teacher, support worker, resulting in harm or potential harm to the child. Harm, potential harm, very important. Okay. Legal duty to report. Upon reasonable grounds to suspect abuse or neglect, physicians are required by legislation. Means the legislation asks us to contact local child protection agencies. So there are specific child protection agencies here in Canada where if there is a suspicion of neglect or abuse, physicians are required by law to contact the child protection agencies to personally disclose all information relevant to the child safety concern. Duty to report overrides patient confidentiality, very important because a child is a minor. So here duty to report is more important than patient confidentiality. This question can even be asked in ethics as well, ethic point of view, that if we are suspecting child abuse and parents are or the person who brought a child to the hospital, they want us not to disclose to anyone, but we have a legal duty, we have responsibility to disclose this information to child protection agencies. And and then patient confidentiality, that is less important than duty to report overrides patient confidentiality, and the physician is protected against liability. So if the physician overrides the confidentiality and tell about the child protection agencies, so the physician will not be liable for that. In fact, it's physician responsibility to do that. Ongoing duty to report. If there are additional reasonable grounds to suspect abuse or neglect, a further report to the child protection agency must be. So child protection agency role is very important in the cases of child abuse or child neglect. All right, keep this thing in mind. Child protection agency. Then the risk factors. Important to remember the child abuse neglect can occur all kind of socioeconomic status. Environmental factors include basically social isolation, poverty, domestic violence, caregiver factors, their personal history of abuse, psychiatric illness, if the mom is suffering from postpartum depression, substance misuse, single parent family, poor social and vocational skills, below average intelligence. Child factors include difficult temperament. Some children, they have lots of temperament problems, they have attitude problem, behavioral problem, temper tantrums, things like that. Disability, if the child is disabled, special need child, developmental delay and premature. Now, management is it do not take an abuse history from a young child. This must be done by trained personnel during a forensic interview. So, if a child comes with child abuse, we are not going to ask anything from the child. We will just refer him to Child Protection Agency. We will involve seniors and trained personnel who will take the proper history, investigate the whole matter. So, our duty is just to report. So reporting is very important. Report all suspicions to the Child Protection Agency and request emergency visit if imminent risk to child and any siblings in the home. So if a mother comes with the history of domestic abuse, domestic violence, and the children are also there, so we need to save the children as well because the children are immediate risk of abuse or threat as well. And then acute medical care should be given to the child if a child is suffering from any injuries, any so we have to hospitalize the child for medical evaluation or treatment of injuries. Arrange consultation from social work and appropriate follow-up is also very much important. Okay, then the physical abuse history is important. History is basically the child may be, the mom gives a history or the father gives a history that is not compatible with physical findings, means they are giving the wrong history and the doctor or physician is suspicious of that, or the history not reproducible, changes dramatically over time, means they're not giving a constant history, and delay in seeking medical attention unexplained by the factors, means for example a child got injury, they present not immediately to the hospital, they came after like 2 days or 3 days, can be a sign of neglect or abuse. Assess previous trauma history, hospitalization history, Family history is also very important of any bleeding tendencies, bone disorders, any endocrine metabolic conditions. Ask history of developmental delay. Next thing is physical examination. Physical examination is not explained by underlying medical condition. Assess growth parameters and compare to past recorded parameters. That for every visit, whenever the child comes to you, we have to check the weight, height, and head circumference. So this is basically recorded so that we can monitor it over time, and it can be compared to the past findings. Then multiple injury is not explained by accidental injury or child development level. The child has multiple injuries and does not look like accidental injuries, they look like non-accidental injuries. Patterned skin injuries like linear injury shapes are made that do not match the provided history, linear injury especially. So it looks like it's a non-accidental injury, not an accidental injury. Injury location. It bruises on areas with abundant soft tissue cushioning like abdomen injury, buttocks injury, genitalia injury, fleshy part of cheek or ear, neck or feet bruises that do not fit described cause. A clinical decision making tool to screen for concerning bruising in children is less than for we don't need to know that, but just we have to see the location of injury, the bruises, we need to look at them, the fractures, if by any chance fractures happened, then where are the fractures, all types of fractures we need to consider in mind. So maybe we can do a bone x-ray, a skeletal x-ray. The immersion burns, for example, if the child is immersed in hot water, scalded skin syndrome, or these things, or burn injury. Altered mental status, head injury, poisoning, eyes, retinal hemorrhages can be there, scalp, patchy hair loss from alopecia, severe malnutrition, oral examination, mouth examination also very important, traumatic head injury. That is a leading cause of death in child maltreatment. Acceleration, deceleration forces, shaking. Shaking of child violently, acceleration, deceleration forces, they can lead to death of the child. It's very, very important. We need to look at all these factors while assessing child abuse. Direct force application, blow impact, or a combination of these forces. Consider red herring. Red herrings mean a slate gray macule or congenital dermamelanocytosis. So, slate there may be discoloration of the skin or versus bruising, cupping practices that may look like bruising. So we have to look at all these factors. So skin need to be examined. So I will give you a rough idea that basically some conceptual idea that if a child comes to you with the suspicion of abuse, what we need to do. First we need to know what is abuse. That is any act of physical, any sexual or psychological abuse that can result in harm or potential harm to the child, and the legal duty of the physician is to report this to the child protection agency immediately, and in this case it will override confidentiality. And then the risk factors we need to consider in mind, we have to take a detailed history and some environmental factors, the social factors, the caregiver factors. Then first if we talk about physical abuse, we need to know about the history like developmental history, any family history, an examination if you find any bruising patterns, any injuries, skin injuries, any eye changes, any hair changes, any involvement of mouth or head injury, all these are very important. Then investigations we need to do in suspicion of physical abuse. Document all injuries on a body diagram, type, location, size, shape, color, pattern, all things are very important. Documentation is very important. So first thing we need to do is document all injuries. Documentation is very important. I repeat, documentation is very important on a body diagram. Photography of skin injuries is ideal. Rule out medical rule out medical causes of bruising fracture with appropriate investigation. Okay, we also need to rule out some medical causes of either bruising or fracture, like we need to do calcium, some electrolytes level like hormonal levels, calcium, magnesium, phosphate hormones like parathyroid hormone, ALP, and vitamin D and albumin. If bruising is present, then we need to see the complete blood count, PTA, PTT, INR, non-Willebrand factor, and the clotting factors. screen for abdominal trauma. So for abdominal trauma we need to look at, for abdominal trauma, we need to look at elevated, if there are serum enzymes, elevated liver injuries there, and pancreatic injury, amylases, abdominal bruising can be seen. So therefore we ask us to do abdominal CT scan. Then toxicology screen also important, overdose or poisoning, suspicion, skeletal survey. That I was talking earlier as well. If we have fractures or bony injuries in the children, select imaging based upon history, maybe CT scan, MRI, okay, skeletal survey, the whole bone X-ray, and the skeletal X-ray is very important. And then neuroimaging, if there is suspicion of brain injury, then CT scan, MRI. We have to examine the eyes of the child to rule out any retinal hemorrhages if subdural hemorrhage detected on head imaging. So retinal hemorrhages also need to be ruled out. In shaken baby syndrome, there can be retinal hemorrhages and we need to rule out that thing as well. Then the next thing here is sexual abuse. The involvement of a child or adolescent in sexual activity that he or she does not fully comprehend and is unable to give informed consent to, or for which the child or adolescent is not developmentally prepared and cannot give. So basically abuse of children in sexually without consent and violates the law or social taboos of society. So, what history we need to ask in pre-pubertal children before puberty? Get information regarding the sexual abuse from the caregiver. We need to ask from the caregiver in the absence of child, and collect sufficient medical information and history to guide medical management. If the child is suffering from any genital pain, any bleeding, any discharge, so now basically we have to take a proper thorough history from the caregiver. Okay, next thing is physical examination. Then the next thing here we can see is physical examination, also very important. Assess for any head trauma, any fractures. Genital examination should be done by healthcare provider with training in the assessment of children or youth who have been sexually abused. And no genital examination important. Instrumentation not required for any genital examination. Speculum contraindicated in pre-pubertal girls. Most victims have normal and a genital exam cannot rule out sexual abuse if exam is negative. Alright. Okay, so while bruises are most often due to minor accidental injury, they may also signal underlying medical illness or inflicted injury. Okay, the following are the red flags for injury in bruising. Baby is not yet cruising, baby is not yet present on ear, neck, feet, buttocks, or not on the front of the body, unusually large and numerous clustered or pattern not fitting with the causal mechanism. All right. So then these are suspicious for non-accidental injury. Okay. Investigations depend upon the presentation, age, sex, and puberty development of the child. Referral to a child maltreatment pediatrician. Child maltreatment is a specific pediatrician. Child maltreatment pediatrician. Sexual assault domestic violence center. Sexual assault domestic violence center is there for examination of the children, rule out any STIs, any pregnancy, consider drug and alcohol screen, alter level of consciousness concerns. So all these things are very important. Basically, we have to involve the specific people that need to be alerted if any such thing happens, like domestic violence center that deals with sexual assault. So domestic violence center that deals with sexual assault, that is we need to refer the child immediately to those. Then the next thing I need to read is neglect. Neglect basically means needs of the child are not met, resulting in actual. So the neglect next is basically means needs of the child are not met, resulting in actual or potential harm. From child and each caregiver separately, we have to take the history, then examination, head to examination, dental care, emotional state. Very important to know. Investigations by image guided by the neglect concern could consider blood test to rule out medical condition, nutritional deficiencies, forms of neglect. Physical neglect, parents or caregiver, like physically neglect, what does it mean? It means that The parents or the caregivers may fail to provide adequate food, clothing, shelter, supervision, and protection from potential harm. So, physical neglect and emotional neglect. Parents or caregivers may fail to provide affection, love, other kinds of emotional support, and children may be ignored, rejected, or prevented from interacting with others. Physical neglect, emotional neglect, and the medical neglect. That means parents or caregivers may not obtain appropriate care for the children, like needed treatment for injuries, treatment or physical or mental health disorders, or delay obtaining medical care when the child is ill. Next topic I'm going to cover today for you guys is developmental disorders. So the first topic here is global developmental delay, early development impairment. Global developmental delay definition basically is significant delay, at least two standard deviation below the mean, with standardized tests in at least two developmental domains: gross motor, fine motor, speech language, cognitive, social activities of daily living in a child less than 5 years of age. So significant delay, two standard deviation below the mean in two domains. So various domains we need to keep in mind while talking about developmental delay: gross motor, fine motor, speech language, cognitive, personal or social. So if there is a significant delay, two basically two standard deviation below the mean, then is the global developmental delay in a child less than 5 years. Two standard deviation below the mean in two domains. So we need to remember the rule of two. Two standard deviation below the mean. Two standard deviation below the mean in two domains in a child less than 5 years is global developmental delay. May predict a diagnosis of intellectual disability in the future. After age 5, intellectual and physical abilities or disabilities are described. Okay. So etiology of global developmental delay, that is important. We need to remember the prenatal factors, the biological factors, means genetic abnormalities, CNS abnormalities, metabolic issues, prenatal environmental factors like teratogens exposure, toxins exposure, infections, so any substance misuse, any drugs, all those things. Then perinatal, that means asphyxia, and neonatal encephalopathy, premature birth, low birth weight, neonatal complications. Then postnatal, after delivery, a neglect or unhealthy psychosocial environment, infections, trauma, jaundice, toxins, exposure to toxins, teratogenic drugs. Then severe jaundice, conjunctivitis can also lead to encephalopathy, right? Some trauma history, infections, and neglect. So most important are the prenatal, then maybe genetic abnormalities and CNS abnormalities and metabolic issues that constitute the most causes maybe. Yeah. So next thing we need to remember is for global developmental delay, clinical features are important, right? Key question in addition to pediatric history, developmental history, and then all the histories, family history, important psychosocial, and problems are there, like feeding problems, seizures, behavior, and sleep problems. Okay, history. After history, we need to do the physical examination of the children. Micro or macrocephaly, hepatosplenomegaly, height and weight we need to check. We need to look at the liver and the spleen and height and weight and brain, and that we measure the head circumference. Then neurodevelopmental examination, including neurological examination, congenital abnormalities, dysmorphic features, head to toe, skin findings, current developmental level. And then we have to check investigations. After history and examination, we need to refer for formal vision and hearing test. So eyesight is important, hearing is important. First line chromosomal microarray and fragile X DNA testing. So chromosomal analysis and DNA testing also very important. Then lab investigations include basically blood work is needed like CBC, glucose, blood gas, urea, creatine, electrolyte, AST, liver, thyroid, calcium, magnesium, ammonia, lactates, and amino acids, and carnitine, homocysteine, copper, all these things, and then urine, organic acids, creatinine, metabolites, purines, pyrimidine. Additional investigation, all the iron, B12, and congenital infections, brain imaging, also very important. We need to see rule out causes of microcephaly, big brain, small brain, seizures. Consider consultation with genetics or endocrinology. So genetics important, endo important. Management depend upon the specific area of delay. Therapy services. So whenever there is a global developmental delay child is there, we need to look at the therapy services like early intervention, speech language therapy for communication delay, and physiotherapy and occupational therapy, early intervention like infant services, drop-in programs. So all the services are very important for treatment of this global. It is a multidisciplinary approach. And the next thing I need to read is after the global developmental delay is basically autism spectrum disorder. Autism spectrum disorder is persistent deficits in social communication interaction. So there will be social emotional problems, non-verbal communication problems, and development maintenance, and basically social problems. Alright. So social emotional, basically there will be abnormal social approach and failure of normal back and forth conversation, reduced sharing of interest, emotions, effect, failure to initiate. So basically child is not developed socially very well. Child will say isolated, stay isolated. He's not socially awkward. He is socially awkward. He's not socially adjustable. He does not talk much. He does not communicate much. Doesn't make eye contact. And the non-verbal communication problems are poor verbal communication, cannot communicate properly, and there will be abnormalities in eye contact. There will be poor body language, and deficits in understanding and use of gestures, and will be a flat face, no facial expressions, and there will be a difficulty in communication. The developmental disorders include difficulty adjusting behavioral problems to suit various social contexts, difficulties in sharing imaginative play. So sometimes the child with autism, they are insistent upon the same routine every day. They have some typical symptoms like they are awkward. They do not intermingle with other children. They do not talk much, communicate much, make poor eye contact, and they have some other features that we will read further as well. But they cannot play with other children, cannot make friends, and they have no interest with their siblings or their peers. Then restricted repetitive patterns of behavior. Some behavioral issues will be seen in those children, that the flapping of hairs constantly, and repetitive patterns, or repetitive motor movements, that they continuously flap their hairs, or highly restricted interest like uh, hyperreactivity to sensory input, or will be also hyper responsiveness to sensory, because your sensory is so much stimulated. There will be respond hyper responsiveness to sensory stimuli. Symptom must be present in early developmental period, can cause clinically significant impairment in social, very important, occupational, other important areas of current functioning. Not better experiment, intellectual disability or global developmental delay. Specifiers: current severity requiring very substantial support, language impairment, intellectual impairment associated with medical genetic condition, can be medical, genetic, and environmental factors. Okay, then we need to differentiate from a neurodevelopmental disorder, from ADHD and other mood disorders, and some other syndromes like Rett syndrome, and we need to look at the hearing and the vision of children as well. Then treatment. Basically, team-based approach is there. We need to work in a team to treat those children. There will be school psychologists, occupational therapists, physiotherapists, speech language pathologists. A multidisciplinary approach will be there. Everybody will contribute. There will be occupational therapists, pediatrician, physiotherapists, speech language pathologists, and psychiatrists. Psychosocial treatment will be family education and support, school programming, behavioral therapy. We have to check the behavior of the child and is give appropriate behavioral therapy, and social skills training will be needed. Then treat concomitant disorders like ADHD, tics, OCD, anxiety, depression. They can occur alongside with this. So they have to look at those things as well, like if a child has ADHD or takes history or OCD, obsessive compulsive disorder, anxiety, depression, seizure disorder. Okay, so pharmacotherapy, any medicine is not evolved yet that can treat autism alone. So there will be a multidisciplinary approach, the behavioral support, the social support, the environmental support, and then we can give atypical antipsychotics for aggression and agitation. SSRIs can be given for anxiety, depression, and stimulants if they are having ADHD. But the thing is, these antipsychotics, antidepressants, they are not given to very little children. So we need to give behavioral therapy, environmental therapy, the physiotherapy, speech language therapy, and multidisciplinary approach involving lots of departments like pediatrician involvement, psychiatrist involvement, speech language pathologist involvement, and then physiotherapist involvement and occupational therapist involvement. All right. Then the next topic, the last topic of today's session is ADHD. ADHD, as you already know, girls tend to have inattentive symptoms and boys tend to have more hyperactive symptoms. Okay, so what are the causes? Causes may be some hormonal issues like catecholamine, decreased transmission, and increased beta activity on EEG, maybe hereditable cause, cognitive maybe developmental disability, poor inability control and other areas of executive function, and basically diagnosis requires onset before age 12, persistent symptoms more than 6 months, and in more than equal to two settings, 6 months in two settings. So requires onset before age 12. Okay. It should happen before age 12, more than 6 months. It should continue and more than two settings. Okay. Interfere with academic, family, and social functioning. So there's a combined type, there's a predominantly inattentive type, and predominantly hyperactive type, and for older adolescents, a combined type. If the more than six symptoms of inattention was, so symptoms of inattention and hyperactivity, definitely we are going to look at them in this table. But if there are six or more than six, then it's a combined type. If inattentive type, more than six symptoms of only inattention. Only hyperactive type, if there are more than six symptoms of only hyperactivity. For older adolescents, more than five symptoms are still good for labeling them as ADHD. Okay, differential diagnosis is not very important to remember, but the only thing we need to remember here that how to diagnose ADHD. So the symptoms of ADHD include basically inattention symptoms, the hyperactivity symptoms, and the impulsivity symptoms. Inattention, careless mistakes, cannot sustain attention, does not listen to when spoken, fails to complete tasks, disorganized, loses things for tasks or activities, distractible, forgetful. Hyperactivity includes fidgets, comes in seat, leaves seat, runs and climbs excessively, cannot play quietly, on the go, talks excessively. Impulsivity, blurts out answers before questions asked, difficulty of waiting turn, interrupts others. Then clinical features are the same like the written above. Okay, present across multiple settings, very important. At least two settings should be symptoms will be there in school, in home, extracurricular. Rule of developmental delays, sensory impairment, genetic syndrome. Encephalopathies or toxin, increased risk of substance use disorder. There's all the clinical features and family history. Also very important to ask. Then treatment. Okay, Now, non-pharmacological treatment is basically psychoeducation, behavioral therapy, parent training important, social skills training important, then pharmacological. First line management is stimulants we need to give to the children like methylphenidate, amphetamine. Second line, atomoxetine. So first line we need to remember methylphenidate and amphetamine. AM. Second line is atomoxetine and guanfacine. AG. And third line is clonidine, bupropion, imipramine. So it goes like this, that we have to use pharmacological management like first line जो है that is known as stimulants basically CNS stimulants, right? Like methylphenidate. Second line atomoxetine. Third line clonidine. For comorbid antidepressants, antipsychotics can also be given. Psychosocial intervention is first line for children less than 6. Psychosocial intervention plus medication. Psychosocial only for children less than 6, but psychosocial plus medication is considered first life line for children more than 6. Okay. Then the next thing is endocrinology and okay, all this. So today we discussed all the topics that I told you that we're going to discuss today. And our session is going to be completed now, and I will come again with another session with some important topics like we will read congenital heart diseases and a bit of endocrinology in our next session of pediatrics. See you soon, guys. Have a nice rest of the day, and please be my study partners. And slowly and gradually, I will gain momentum and speed. And if you like my video, and please give a thumbs up and subscribe and share as well. Thanks, guys. See you soon.